saying that.
Fair enough.
Anyway, that's my way of saying thank you for turning them off. And it is my great pleasure, personal and professional, to introduce Carol McLaughlin today. We've known each other since you came to campus almost.
Almost 10 years. Yeah.
How many years ago?
Oh, probably at least 8 or 10. Yeah, 8 to 10 years. Yeah.
It's interesting. We don't. Carol and I don't have that many opportunities to meet, in part because she's got so many responsibilities now. She's been discovered by the university, which is always a dangerous thing to have happen in the last 10 years. She's gotten dragged into many things, but she did have a more focused beginning, which I learned about both a little bit over lunch and because she went to a university very nearby here, started her career in the university at Princeton in the Woodrow Wilson School of Public and International Affairs. And then went on to do both her medical degree and public health degree, master's in public health at Johns Hopkins, which is also down the road and one of the best known places in international public health. And in particular, I guess some of the more interesting things that are going on in public health. However, you came here under slightly different auspices, which is interesting.
Exactly, yeah.
And how we met was that she was part of what is termed here as the founding team member, or a founding team member of the Center for High Impact Philanthropy. And that is associated with the Wharton School of Business, I believe, isn't it?
And the School of Social we're housed in the School of Social Policy and Practice.
Right, but you have to be associated with Wharton because that's where the big bucks are. Excuse me for relaying that information. But we are part of this spread out, Carol and I and others more recent like Amina, part of this spread out global mafia around the university, which is, we have quite a few members, although we're not all known for it. I mean, you have this list of affiliated faculty, of which Carol is one of our esteemed members, but we kind of represent a broader group. Not all of whom have been directly related to IEDP. So I just want to say that, and you may have already Googled her, probably you have. She's also worked in Latin America, Thailand, Vietnam. I'm not sure. I think there's a picture up here. That's Philadelphia, but there was another.
There was one, yeah.
Exotic land.
Exotic land of Philadelphia.
The obligatory Franklin from less developed city like Philadelphia. And she also did work at Harvard and all the good places, and finally came to a good place at the University of Pennsylvania. So I just want to say what she is doing now. I was hearing a little bit of this over lunch. She is, and I believe on the clinical faculty, Division of Infectious Diseases at the School of Medicine.
Exactly. Yep.
She is an attending physician. She does real work at a disease clinic at the VA Medical Center here in Philadelphia. She is still working with the Center for CHIP.
Exactly.
The acronym. An associate fellow for public health. You teach in public health.
I do, yeah.
And a faculty fellow in the Center for Clinical Epidemiology and Biostatistics. And she's affiliated member, most importantly, of the IEDP.
Exactly.
So the rules of the game are, as we've had before, she has about 45 minutes, plus or minus, to sort of give a presentation, which you are free, as she says, to interrupt as you like, and please do. And then we will open it up to a broader kind of conversation on anything you like, and we will try to end a little bit early, around 3:30, 3:35, something like that. So I think that's the end of my introduction.
Wonderful.
Except one thing, that I've asked her to start out to tell us a little bit about herself before she gets into the professional part. How did she get to be who she is, which I think is interesting.
Great.
all yours.
Why, thank you, and thank you, Dan, and thank you, Amina. Thanks for having me here. I'm really excited to come talk to you, particularly because I've had so many fantastic master students from this program in my classes, and so I've got to know some of you, and I have to say, you're a wonderful group to work with, so I was excited to come, and also thanks for those who I had lunch with, too. It was great to meet you, and have the chance today to kind of talk about, I'm going to talk a little bit, I kind of have my talks separated into two parts. One is I wanted to tell you about the Center for High Impact Philanthropy, which is a project a long project I've been working on for the last 7 years here at Penn. And it kind of speaks to a lot of the things I'm passionate about that I think cross many of the things that I think many students in this program might be interested in, which is interdisciplinary work that actually, makes change in the community and hopefully gets the best evidence so that social change happens. And I'll talk a little bit about how that came to be and how we formed the center and the challenges, and also kind of in the campus. And then the second part, I'm going to sort of more kind of tell a little bit about my own personal passions in public health, and also I think how a lot of how they cross educational programs, and where I see kind of what I hope to be doing in the future and the kind of work I'm sort of getting more involved in. And so as Dan said, I'm actually a native Philadelphian, so hence what brought me back. So I actually grew up in Havertown, about maybe 15 minutes from here, and had moved not very far away, but within the kind of East Coast for college and medical school and public health school, and then being in after medical school, there's a long kind of haul of training programs. So I spent 4 years doing a primary care residency program in internal medicine and pediatrics in the Boston area. And then I came back to Penn to do an infectious disease fellowship. So my specialty is actually in infectious disease, tropical and travel medicine. And after that was when I was doing more kind of in-depth epidemiological research, working with the Philadelphia Public Health Department, where I realized that my passions in some ways had all along been working with communities and working with the nonprofit sector. And I think I also found a somewhat of a frustration when working with the nonprofit sector that all these fantastic programs that I thought were doing such a great job were not getting the resources. And I'm like, don't these donors understand these are great programs, and I don't understand why they're funding that when this program is the best model and it has evidence. And so I was somewhat frustrated. I knew I wanted to have my long-term career in working with community-based organizations, and I was like, this sort of frustration. And so I think there was, right at that time when I got a sort of a call actually from my mentor, who was one of my master's thesis mentors after fellowship, Shariki Kumanika, whom some of you may have known. She's an obesity researcher here at Penn. And she was like, Carol, I saw this job notice for this crazy new center they're creating in the School of Social Policy and Practice called the Center for High Impact Philanthropy. And she's like, you're kind of like an oddball kind of person because you like academia and you like the research, but you really care about programmatics. You might take a look at it. And when I went to go meet with the person I was interviewing with, I realized this was a perfect opportunity, a perfect fit. And sometimes these come around, sort of once in a lifetime, where the idea is that donors, whether they're small family foundations or individual donors, often don't have the information to make the best decisions about social programs. And how can we make sure that the information that happens from Dr. Wagner's studies or all of your PhD dissertations or your faculty actually makes it to the decision makers who actually decide policy or where the funding goes. So I was really interested in how can you close that circle between research, which I care a lot about and I love research, communities, which is what I want to do, and then a lot of people who actually, whether they're in DC as policymakers or they're the philanthropists who in our capital society have a lot of the wealth and resources. So how can we make that happen? So hence I ended up, one of my sort of journey from the last, 7 or 8 years trying to really learn the sector. And for me, I didn't know anything about philanthropy and donors or finance. I mean, I'm a epidemiologist and scientist and clinician. So it was
I know about blood donors.
I know about blood donors, but not. And so it was a big education. And I think one of the fun things for me about it and challenges was I thought I was done all of my training, all of my everything else. I'm ready to start, and I'm like learning a whole new area. And the fun thing about it is that I was the only person on my team who had any of those skills. And so I started working with a lawyer, an MBA, a Wharton MBA, a PhD from Rand. So we all had these different languages to speak, but we knew that this is the way the world worked. Is that people are going to come and I remember a conversation at our first international, what do we call it? The international, what was the first conference? The GDI. We had the Global Development Initiative that Dan kind of spearheaded. We had a first conference, and it was very interesting because there was one of these donors there, and there was a nonprofit there, and I remember them kind of having this somewhat awkward meeting, and the donor saying something like, I just want to go where I can buy the most DALYs. And if people know what DALYs are disability adjusted life years. And I think I saw the nonprofit person go, like their face just dropped, being like, DALYs you can't buy, they're not for sale, these are children's lives. And what he really meant to say is, I just want to do the most good with the money I have. But the languages just kind of cross. And I realized at that moment, I'm like, this is a real space where something could be done to kind of break down languages, to try to translate the different communications patterns and all, to try to hopefully, make it so good intentions can be turned into good decision making and good programs. So it's been a fun adventure for me. So I'll tell you a little bit about, so I wanted to start out telling you a little bit about the center and kind of what we do. And please feel free to stop me at any point in time, ask questions. If anyone's been in my class before, I'll try not to go off on tangents because I love when people ask questions because it takes me down a road that shows that maybe something that you're even more interested in this and that I'm happy to talk about. So when we think about kind of, there's so many unmet needs in the world, and these may be, and this is a photograph from Haiti, when you're thinking about access to clean water or nutrition, or you might be thinking of the same thing in Philadelphia, whether it's, rates of obesity or violence. And so we know that there's so many more needs than we currently have the resources for. And so we could definitely use more resources, human resources, those kind of things. And one thing that I didn't realize, when you ask people, they're saying, in the philanthropic world, who do you think is most, who gives the most money? And I think most people would be like, who would you say the first person? What do you guys think? Gates Foundation. And maybe, and to be honest, globally, that's true. But if you look at US-based programs, who gives to the US, it actually, this is in terms of dollars, individual donors give 75%. And this was like I said, I had no idea of anything about this sector. I didn't know anything about it. So it's interesting. So huge part of the philanthropic marketplace. The other interesting thing is there's been surveys done that where most people don't really, I think the fundraisers understand individual donors, but we didn't really understand what are their needs, what are they, what's missing in the marketplace. A lot of people have stories and that kind of thing, but if you really ask them, they've done a recent study, is that people are really interested in nonprofit or whatever performance, how good are they making the change that they said they're making. And then they also ask questions about, well, what are your needs that you have met and not met for information? And people will say, okay, well, now I can get information about, their financials or about their leadership, but what about effectiveness? How effective are they at the ground? And impact data were key unmet needs, which I thought was really interesting. So when up to this time, I think a lot of individual donors, when they'd say, oh, how do you choose a nonprofit to give to? If they'd be like, oh, I look on Charity Navigator, and if it's 4 stars, or I look at something called an overhead ratio, which is, how much money is spent on overhead versus program. But if anybody has ever run a business or anything else, that there's no, why does overhead ratio have anything to do with the outcome of a project? And you might even say that, well, if you're a new project, you want to spend more money to invest in your capacity of your workforce. And you actually, by doing that, may get better outcomes for your community. So don't you want to look at impact? So it was a very interesting space. When you think of the word sort of philanthropy, it actually is kind of about promoting human welfare. So that's its sort of goal at its root. And this kind of idea of high impact philanthropy is sort of a new name, but it's an old idea in that, everyone back from Aristotle to Ben Franklin to Warren Buffett, when they talked about, what were some of their hardest jobs, it was actually thinking about if I had money to give away, what should I do? Where can I make the most impact? It sounds like a really easy question, but when you really come down to it, it's really hard to think about, what can be the best use of money to make change? And so it's really not how much you give, but how well do you give to make change? And
can I just say that it just occurred to me, and just to plant this idea in your heads, we might want to come back to it. It's really the same question you have about yourselves, because you're human capital. How do you invest yourself? What is it? What's a high impact individual?
Yeah.
So I mean, to sort of break out, it isn't just Warren Buffett.
Yeah, you're right.
It's also all of us.
And it's kind of an interesting segue, because when I was thinking about taking this job at the Center for High Impact Philanthropy, I thought to myself, I can go right to clinic and I can start seeing patients and I can have a good impact on a certain number of people. But I also thought to myself, I'm not going to be somebody who creates a new invention or creates a vaccine, but if I could somehow get the programs that work with these ideas on and change donors' behavior, then I could probably have much more of an impact than I could probably have as an individual doing something. So I was thinking that same way. If I really care about my social impact in life, where can I do the most good, given vis-a-vis where I can have influence? So I think you're right. It's a question we kind of all ask ourselves for our own lives. So when we started the center, this was back in 2006, 2007. We had a small team. There was like 4 or 5 of us, and had a room over in 3815 Walnut Street, and the 4th floor, which is in between like 2 fraternity buildings, and Amy knows, well, my neighbor in the office. And it was so fun to kind of be working in somewhat of a startup, I'd say. It's like, we're like, what is this idea? How can we make of it? We spent a ton of time just talking to people. We talked to a lot of donors. We did in-depth interviews. We, talked to nonprofits, what are their frustrations, and we really tried to come up with some core concepts of how we could make change. And I think we really came down to our whole methodology was around these sort of 3 concepts. One was, when we talk about high impact philanthropy, it's about social change. So a lot of people give money, and their idea is to put their name on a building or to give back to their university, which I'm sure Penn loves. When you graduate, you'll get lots of mail, like you probably already do, or to give back to your synagogue or your church. But this is a different type of philanthropy. This is a philanthropy of the money or the resources you have when what you care about is making change in people's lives. As sort of so this is the philanthropy we're talking about. And the other goal was that it's informed by the best available evidence. So we wanted it to be, how can we get evidence-based sort of practice? And then the last concept, which I have to say was really difficult for me to come around to, which was something called bang for buck. Like, how could you get the most for your money and sort of the efficiency? And it's very funny because we've had lots of heated discussions, because on my team, I'm the bleeding heart, and then we had the Wharton people who are all about efficiency and the kind. But sort of I've come around to it in some ways, understanding that if I really care about communities and the people I'm working with, I don't want money wasted. So you want to make sure you're not wasting money. So while I don't like the cold kind of thing about it, but I understand it from a perspective, if you're using money here and it's not making a difference, then in some ways is wasting money that you could be using to help other programs that work. So I've kind of come around a little bit on the concept, but I'm not. So we always try to think about how much change do you get for what you're investing in. And kind of in this kind of box that we sort of think about, this was kind of a new area for philanthropy, because has anybody work in philanthropy? I was just sort of curious. Sometimes we'll have people who are we're in fundraising, or does anyone work in nonprofits before they came here? So a lot of people, and a lot of people may afterwards. So this, and one thing fun about this job, and my part of the job that I love, is I get to work with all the nonprofits. So I get to work with them to get their data to kind of see what's working. And so I've met so many nonprofits over the years and looked at their work. But many, for philanthropy beforehand, there was a lot of research on philanthropy. So there's centers that study philanthropy and study donors. And then there's things that people that help donors make decisions in their philanthropy, where they'll say oh, what would you like to do? Let me help you craft a foundation. It's all about you and your goals. But really what we're trying to do is say, if you have an end goal, then work backwards from that. So this is not about being donor-driven or even research-driven. It's about being impact-driven. So that's the kind of concept that we tried to to kind of craft. And everyone says social impact. It's a word that you'll see out everywhere. And everyone's kind of like, well, what does that actually mean? We've written a lot of different papers to kind of discussing it. And it really is a meaningful improvement in someone's life. And it's often defined by that person. You know, we spend a lot of time thinking about sort of definitional things. And then we've come up with sort of questions that we try to ask ourselves in our analysis, but as well as we hopefully teach donors to work on is, what is the impact that you're trying to, you always start with the end. What's the impact that you're trying to seek? Is it, you know, the educational outcomes for the children? Is it, you know, having them be able to have enough learning skills so that they can get a job afterwards? And is it meaningful to the communities you're working with? Second one, so if you're going to give money, well, what do you know works? And what's promising and what doesn't work? So things like, I don't know if the program Scared Straight, I don't know if you've talked about that in any of your courses where, has anyone has worked with Scared Straight before? Does know what it is? So they used to bring in sort of ex-cons into the classroom and tell them all about kind of what jail's like and stuff like that. And they thought, oh, well, this will be a good way to keep kids out of school. Well, it actually increased, you know, delinquency, because in some ways it made it not as scary to kids. It actually, so it until they actually looked at it, it seemed like a good idea. So sometimes good ideas just don't work out unless sort of they're tested. And then the other question that comes back to that sort of bang for buck, when there was success, what did it cost? But not only in terms of dollars, but human resources. What will it take to move the needle? Because that's an important thing if resources are scarce. And then the other question we sort of think about, and sometimes with our colleagues in other schools here, are what organizations are best positioned to achieve the change? So one of the difficult things for me is that donors will always say, okay, well, that's great. You tell me about this great model, but who do I write the check to? And I was always uncomfortable about that because we don't have enough time to go and evaluate all the nonprofits in the world. So what we try to do is give characteristics of implementing organizations that do this well. And then we'll take one or two really good examples and use them as case studies. And I think that's our way to be able to kind of tell a donor, you know, here's an example of what one looks like, but there's many different nonprofits out there that you can find. And here's some questions to ask them when you go, you know, when you go interview them or you're thinking about them. So that's one thing we don't do. We don't give star ratings to nonprofits, but we do use ones as case examples. And we've gotten to know a lot of them, for example, and some of the ones that I think Dan has introduced us to, so Save the Children and other ones. So we've looked at a lot of their programs.
Maybe we should stay on that just for a second, though. I'm just wondering if there are people who have are you going to come back to those issues?
Oh, which one?
These four?
Yeah. Mm-hmm.
You're going to come back to that?
Mm-hmm.
Okay.
Yeah, well,
I think people will be interested.
Yeah, and I have some examples to show you what each one of them are. The other thing that I think that for me became a really fun thing is we got to decide how we were going to create analyses. And coming from as a researcher, you know, I always felt like, okay, well, we need a rigorous, you know, I came from the medical side of the world, evidence-based medicine side of the world. So you have to use, you know, randomized trials and all of these kind of stuff. And so we start, you know, working on, you know, research, you know, modeled analyses. But quickly we learned that, you know, most of the things in the social sector do not have randomized trials and do not have this kind of evidence. And then secondly, is that even though if you have a randomized trial, you know, the randomization, I mean, the whole process of a clinical trial means that you've kind of controlled for a lot of the things that we actually care about when we're trying to generalize. So will this trial be applicable in other countries? So we really need those kind of cultural differences, those kind of areas. And so how do we get that information? And so we created a whole nother circle on the field experience. So what is the knowledge on the ground? What's in the gray literature? What's in the minds of the practitioners on the grounds? What are the case studies we can do? And the next thing is there's a lot of people that work in these disciplines who have just really the knowledge of, and can kind of interpret these from just years of experience. And whether that's a community member, whether that's a policymaker, whether it's just somebody who knows. And for us, it's where all three of those point to somewhat of the same thing. And that's what we call this sort of this broader definition of evidence. And you know, we've gotten a lot of pushback from our researchers at Penn saying, well, this is, you know, this is where everything should be. But really from like what we found in the field is that there's so much from enriched stuff in this one that trying to figure out how to codify that for donors has been probably the best part of the job, because they can't get their hands on any of that kind of materials. And it's hard for nonprofits to get it out there because they don't think that it's worthy of publication. So it's sitting in the minds of a lot of practitioners.
So can I?
Yeah.
I won't be the most difficult self. But I look at those circles, and it strikes me that all seems very reasonable. I just wonder if there's been any shift in the shape of those circles in the last 8 to 10 years, so that some of them are becoming more important or less important.
Yeah. It's sort of interesting. The informed opinion, I say, is not, it's just kind of, is it sort of a check on our stuff, I'd say, more than anything else. In certain sectors, there's much more available and published literature than in other sectors. So in some sectors, we have here. The other thing is the field experience. One thing that's really exciting to me, I work in the public health space mostly, and in the last couple of years, there's been this shift. When I first finished my, my fellowship here at Penn, I was really interested in health delivery and looking at how do we get things to people. And everyone told me, well, that's not research. That's, you can't publish anything. That's program evaluation. That's quality improvement. NIH doesn't give dollars for that. Nobody does. So I'm like, well, that's what's important, though. That's where the missing link is. And that's, I took this job and started going. And now the shift from the National Institutes of Health has been, well, this is the most important thing. And we call it now implementation science, dissemination science. It is like where all of the new grant money is, because they understand is that we have all of these things that we know work, but we don't understand how the best ways to get them out to people and disseminate them. So it's a whole, I would say, growing, exciting field, and lots of new journals and lots of new conferences. And so that sort of space where these kind of mix, I think is this really cool area.
Just based on your answer to Dr. Wagner, the informed opinion has sort of become a check mark as opposed to a focus. How are you making sure that the community is involved?
Yeah. Yeah, no, and I think we find that there's a lot more research in the dissemination kind of side that actually asks community their opinions or does a lot of surveys. So that actually is now coming out much more in the literature. So that is actually more included, I think, is being pulled in more than I think it was in the past. So we've actually been able to find that for a lot of our work.
That's a good question. And my question, follow-up, is I'm sort of curious. Implementation science has been on my radar now for a few years, for maybe the same reasons. I pay attention to the health literature.
Yeah.
But in education, has implementation science ever come up in an education class? Anybody? Show of hands. Anybody hear the term? Yes? Yeah? Only you?
Unpack that term.
No, you can't unpack that term. Because if you can't unpack, if you don't, obviously.
No, I haven't heard the term.
Okay, that's all I was asking. Yes, we could ask, and we should.
Yeah.
But I'm just getting a sense. It's interesting. So Tukunbo is the only person who has said that she has heard of implementation science. Amina, have you heard of implementation science?
Heard of implementation without the science.
No, it really matters. It really matters. Because if I could suggest that the addition of science to the word implementation is the essential resurrections, pardon the term, of the whole issue of practitioner role in the development of this what works idea. And the key protagonist, I would say, is, who I'm referring to? The current head of the World Bank was one of the people who was the biggest promoter before he became. This is Jim
Kim. This is implementation science is his baby.
Exactly.
And he's trying to get everybody at the bank to
But it's interesting,
be trained
because in
in.
education, we don't use that term, and it does. You're quite right, Rachel. It makes a difference to add that word science to it, because it reifies the sense that there is really a science, not just an opinion.
Yeah.
You have various.
Oh, great. Yes. Okay. You always raise all these controversial. Yes.
Well, I was just going to say, I would argue that's what we're trying to do with our policy briefs. I mean,
Yeah.
the people that we're writing to know what they're supposed to do, but we're arguing for the how and the why.
Yeah.
I mean,
Yeah.
that's just my
I think the how is the exact question. So if you know something works, but how do you actually get it into community X, Y, or Z? How do you scale it up? How do you keep the practice going over time? How do you make sure when you change to another organization that they keep fidelity to the model? These are the sort of questions that implementation science tries to kind of look at. Yeah.
Yeah, I would say I definitely agree that there's a gap between the education and this, I guess, evaluation or implementation science. Because I'm in a program evaluation class now in the school of social work, and I'm working on a program in a nonprofit organization that's designed to help kids who are on a really low level of reading to increase their literacy. And that has been really interesting for me because it brings in the educational component. And so translating that, the organizational format, into, or the education into outputs and outcomes.
Yeah.
So trying to talk to stakeholders about what that means and how you even create that has been interesting. And so then I start thinking about schools and how that kind of framework probably is not really happening, like when you're talking about achievement on tests and standardization and stuff. So I think definitely a lot more.
Not more. Yeah, I would say it's really, one of the things that's fun about working at the Center for Impact Philanthropy is that while I come from a health background, my colleagues come from educational background. We've done a lot of work in education, and we'll both be like, also the disciplines have very different languages and are at different points. And so we'll also find, all of these sort of, comparisons, good and bad, kind of between how people do program evaluation or think about evidence. And so it's a really rich environment to kind of learn and share those kind of things. Yeah.
Just sorry to worry. I would push back on the idea that the word science on implementation has that much of an impact on what it is. I think it's a marketing tool. I think calling it implementation science gets it out there so people pay attention, maybe give money to programs and create fields of study and those grants. But for us to study how to implement is the science of implementation, even if we're not phrasing it that way.
Yeah.
I think the policy briefs, the management implementation section on our tech proposals, or even any way we. I mean, I'm not studying how to educate people because not my thing. I don't know anything about it at all. I talk to children mostly, but how to get those things out there. I see kids. I'm not very friendly. But how to get those programs out there is what I'm much more interested in. I think just by virtue of studying the implementation.
Yeah.
That's sort of what I'm looking at.
Yeah. I think you're all seeing that how important it is the delivery side is so important. And for the public health and for medicine side, that was never seen as all of the funding and everything else was in the discovery and find the vaccine and prove that it works. But then, after that, it's cake, just get the vaccine to kids. But you're well, how do you get it to kids? How do you get them to accept it? How do you get it in programs? That was not something that was really a prime part of research or even seen as science or important. And so because it wasn't as important, it didn't get funded sort of in a research capacity. So I think it's also, it's a word that I think is also, it's interesting though, because I've gone to a couple of these conferences on implementation science, and people are now developing very similar to they did for evaluation frameworks and what's the highest level of evidence, all of this sort of theory behind it and trying to make it into a way that everybody does it the same way. So, and which could be good and bad, I think, in some ways. So it's kind of at its infancy, I'd say.
I hadn't heard the term implementation science, but I have heard the term deliverology.
Okay, wow, okay.
So that's Sir Michael Barber from Pearson.
Okay.
Of course. He's been doing a lot of work in Pakistan with the Pakistan government, and so his big thing
It's deliverology.
He's also written a book for the U.S. education system about how we deliver education.
Deliver.
Of course,
That's cool.
from a very interesting background, given that he's the head of education.
Oh, interesting. Okay, cool. Does somebody else have a question? Yes.
One question is that this is from the perspective of program planning. But my question is, when we have donors, we need to adjust. So they give money, but generally they tend to have an agenda or certain things they want to say. And there are trends in international development that do not always match the research. Like we saw in class yesterday, sometimes research is ahead of its time. How can you match the donor's agenda with efficient impact?
Yeah, no, this is a great question, because I think the work that we do, I think, doesn't resonate with every donor. And you're going to have donors who are going to say, like, look, this is what I want to do, and this is what I give my money to, and no matter what you tell me, I'm not changing my mind. I think what we're trying to do is for those donors who are open-minded and saying, what I really want to do is make sure that children in Malawi get the learning tools they need so that they have the literacy skills to graduate. So if they come in it from that angle, then we said, oh, well, let's try to figure out what that kind of best program is. But if a donor is already set on what they want to do, we don't try to change them because we also know that it's probably not going to be successful. The other thing we try to do is work with what we call the infrastructure of philanthropy. So like I said, the olden days, you'd go to Charity Navigator, a donor would look for a 4-star charity. But there was no way for them to say, well, if I cared about impact, there's no easy way for me to find it. So our executive director, Kat Risqueta, is now, she's on one of the advisory boards for GuideStar and also works with Charity Navigator 2.0 to try to get impact data into, so if donors want to look at it, that nonprofits have a place where they can upload their impact data. So it can be something that can be a default and be easy. So we're also just trying to kind of make it so people have access to the information, and also to help donors to sort of educate donors that if they want this kind of information back from a nonprofit, then they should also put that extra funding so that the nonprofits have the capacity to be able to measure what they're doing and to course correct. Because it's, as for everyone who's worked in organizations, it takes capacity and it takes resources to be able to measure and to manage. So that's the other part that we do play. Cool.
You're going to have a hard time getting.
No, that's fine. I don't. If we stop here, that's fine. You know, I have no agenda here.
So credibility of impact data.
Mm-hmm.
Who puts the stars on there?
Oh, for the. Yeah.
You know, like my program's great.
Yeah.
My favorite term is the word reach.
Outreach,
We
yeah.
reach 1 million kids.
Yeah.
But what do we reach them with?
Yeah.
I mean, do they get
Yeah.
an email? I mean,
Yeah, yeah.
You know,
These are great, and so we don't have. There's no way right now. I think it's at its infancy to get across nonprofit data. The other thing that is really hard is all different programs have different outcomes, and that's okay. You know what I mean? And so you should have nonprofits should be able to say, this is my goal of my organization, and did I reach it? And here's how I looked at it. So we're not trying to get everybody to be on the same apples and oranges in all the places, but there are some things that if you're trying to get the same apples and oranges, then maybe there's some universal metrics or ways to measure them. Fruit that you could use. So for example, in health, and sometimes in health maybe a little bit easier than in some other sectors, because sometimes, you know, unfortunately death is death, so it's something that's you can measure, or there's some ways that that there are metrics that people have really tried to get to, universal metrics that can cut across programs. So for example, in health, that metric I was talking about, the disability adjusted life year, or the DALY, is one that now there's a whole Center for International Health Metrics and Evaluation, which almost all programs internationally, they'll try to get things into DALYs now. So they're really trying to do that. And that's actually not just for donors, that's for ministers of health, that's for the World Health Organization, because they want to be able to kind of measure health, and they want to keep ministers of health on task to do the things they said they do. And they also want to find out, well, where are people succeeding, what's working, what's not. And so some areas, you know, we are able to kind of come up with universal metrics and use them across programs or countries. Yeah.
So speaking of those universal metrics, and you talked about how, you know, the Center for High Impact Philanthropy really focuses on looking at characteristics of good NGOs, and then also coming to the table as a medicine person and sort of having these debates with business people for bang for the buck. So one of the big takeaways that I always got from your global public health class that I think translates to education is that it's a lot easier to, you know, implement a physical change in context than it is to change people's behavior.
Yeah.
And one of my favorite examples was like the high morbidity rate of traffic-related accidents.
Yeah.
And it's a lot easier to put in speed bumps than change driver behavior and get people to drive slower. So
Yeah.
when you're talking about efficiency and bang for your buck,
Yeah.
how I think that in the education field and in the medicine field, we see
Yeah.
that you want to go upstream and change behaviors.
Yeah.
When you're having those conversations with board members,
Yeah.
how do you sell
Yeah.
that, or what do you think
Yeah.
is important?
Well, it's hard, and I think that's even if it's not business people, it's also policymakers in DC or in Philadelphia. I mean, so you're trying to get an outcome, and you know how hard behavior change is. So I think it's kind of, you have to weigh kind of the upstream and also how effective are your tools. And there are some, and I think we're learning much more about behavior change and the things that actually work, and I'll talk in a couple slides if I get to them, about some methods that actually, there's a lot of great, I don't know if people have heard of positive deviance or like peer-based moms groups or like the power of peers and a lot of the stuff that I think we as, I just know in our public health community that we have not tapped into as much in terms of understanding the motivators of people's behavior. And so, for example, there's a fantastic group at Penn that looks at incentives and how, and what drives people's choices and understanding them. And so the more that we understand what drives people's behavior change, I think the more that we'll have better success at changing people's behavior. And I just feel like we don't give up on it yet. However, I know so my other hat is as Dan was saying, is that I'm a infectious disease physician, and I actually have a HIV clinic over at Presbyterian. So I think of this from a perspective of trying to get people to wear condoms, which you would think, okay, there's so much data on like how important it is and how much they work to prevent sexually transmitted infections. It is so hard to get people to change their sexual behavior. And we've done, there's so much literature out there of every kind of messaging and programs, and it's really hard. And that's why people are really working towards trying to get a vaccine, because they understand that no matter how much we're doing, it's still behavior change, particularly on certain areas like people's sexual preferences, things about food and what you eat. Like there's things that are really hard to change unless you teach kids really early on before they have those habits formed. So I think we're learning more. I think we have a lot more to learn, but I'm not giving up on behavior change yet. So. But cool. Can move my next slide. Okay. Oh, so these were just the kind of things that. We spend a lot of time thinking about, again, the philanthropic goal. Is it meaningful? And then kind of, I think somebody asked this question about sort of indicators. I think you brought up the whole idea of log frames. This is probably what you're doing in your program. This is probably Dan's kind of, I remember your paper on proxy sort of measures. And I think what we did this project last year working with a lot of different nonprofits to understand, because there's reasons why people evaluate. There's a lot of people that things are driven down by your donor and saying, you must measure this because I say you have to. And what we're trying to understand with donors is trying to get metrics that are helpful to the organization so that they can course correct and improve and be a learning organization. So we kind of call that measuring and managing to impact, not necessarily measuring because you have to for compliance sake. And so we put out a paper earlier this year called Beyond Compliance, sort of like how measurement and metrics should be helpful to organizations, both on the day-to-day, but also to look at their impact maybe from a before and after of a certain time frame. And this is just some examples, is that, this is, a bed net program or kind of another disease I work on, which is malaria, is that you put in money in staff, you train and deliver. You can look at, so for example, Dan was saying is like, oh, you might put up, a nonprofit might say, oh, I delivered, 1 million bed nets in Senegal and other countries of West Africa. Is that the impact? Well, do you know if they even put them up? Do you know if they slept under them? Do they know if they're effective? So for some of these, we have to, go back to, the number of households that are covered, and then we actually have to think about, can we get closer to the actual final metrics? Now, sometimes this is really hard, and this is very expensive. And so we don't expect every nonprofit to do it. And there's modeling programs that are great that are out there in the last 5 years that a nonprofit or an organization can plug in their numbers and kind of model this out if you can't measure it, because sometimes it's harder to do. I don't know if there's many in the education space, like modeling programs that will, so we know the effectiveness, if people actually sleep under a bed net, we know that it's about 48 to 50% effective in preventing malaria. So then we can plug in the malaria rates in that country and try to figure out the change in coverage and what that might translate into.
We must, but I'm
So.
not actually sure. I'm not sure how
Okay.
to answer that question.
So there's I think, particularly in the public health field, there's a lot of exciting modeling programs that we have. This one is called, that I'm mentioning here, is called the Live Save tool. And it was developed by a group of child health epidemiologists at many of the schools of public health in London and Hopkins. And it's housed, if anyone's interested, it's housed at the Johns Hopkins University School of Public Health International Health Programs. And it's run on a Spectrum software, and probably I would say most of the nonprofits who get grants from USAID actually plug in their numbers, and USAID helps them, and they use this to give reports to Congress. So, interestingly.
Yeah, I mean, doesn't it sort of run up against this issue of implementation science? Because here you're essentially plugging in the impact of different programs around the world as if they were the impact of a vaccine was more or less all the same in terms of implementation.
Oh,
I think I'm wrong.
Yeah.
But it's
Well, I think it's also trying to think about the translation to an audience who makes decisions who doesn't understand the medium in term. Like, so I don't think there might not be senators or whoever's making decisions that understand what it means to have 30% more children sleeping under bed net. They're going to be like, what does that mean? And then we can tell them, oh, in this country, that translates into approximately this change in children's lives.
Let me give you an example that you probably read in the paper. Some of the students here will be aware of this. Maybe not everybody, but there's a lot of talk now nationally, Obama and others, and internationally, about the impact of early childhood interventions.
Mm-hmm.
We need more preschool, we need more early education, we need more programs to help kids who are disadvantaged. Here in the United States is sort of Obama piece, but of course they say this internationally, and the data set that's used is largely from Detroit, Michigan.
This is like Heckman's data?
It's the Ypsilanti well-known study that has demonstrated in the U.S. sort of a 10-to-1 ratio. Every dollar invested gives $10 back in terms of lower recidivism in prison and early pregnancy and drugs and so on. So one of the problems with that is, has there ever been a country that, or even a place outside of Detroit, Michigan, where that's been replicated? Well, only once in Chicago, and it wasn't the same, but nonetheless it was a similar kind of community in Chicago. Would that apply in other countries? I mean, I guess it's one of the questions. How do you, when you deal with saying, somebody comes here and say, I have $10 million, I want to help kids. You say, well, we have this research in Detroit that showed a 10-to-1 ratio of impact. They say, well, is Detroit the same as...
This is a great question. I think this is why we need implementation science, because I think we often don't understand the factors that are core to a model and the things that will then also shift the impact factors.
How do you do that? As I mean, you're
and I think
very small organization.
No, so we actually don't do that. What we'll do is tell them, this is the data that we know from this program, whether it's been replicated other places. So we'll look at, and then we'll tell them sort of the caveats. You know, what do we think made it successful there? And so, for example, a program that we looked at in India was one of the areas that in child health is that more than 40, almost now 50% of deaths in children occur in the first 2 weeks of life. And more than half of those occur in the first 24 hours of life. And there was a program started that looked at home visitation, so that there's somebody, a community health worker that's there at the birth, but to take care of the baby, and not just the midwife who takes care of mom, that can dry the baby and give kangaroo care, and can use special ways, clean blades to cut the cord, and do early breastfeeding, and then check on the baby at 24 hours of life, and if it looks like it has infection, start antibiotics and refer. Well, they found that program actually decreases deaths in neonates by over 50%. But they knew that they probably weren't going to get that same outcome when they translate it to other places. But they were able to identify, based on what the kids would have died of, what they protected them from, what the profile would be of where it might have that similar impact. So where infection rates were high in children, where there were a lot of home births. So they're not saying if you did this in a place where people deliver in a hospital that it would have the same impact. And then what they did is the Saving Newborn Lives program, which was actually based out of Save the Children, replicated this in 5 different countries to try to see out what were the factors in different places that worked and didn't. And they had, a range of outcomes, but it was all between 25 and 50% outcomes. And so those are the kind of data that we'd love to have. We'd love to take a model, shape, this is a core program, and then test it in different settings. Unfortunately, that's really expensive, but when you have something like that, I think that gives a lot more evidence that this is a core practice that might be a universalism rather than just have we won't say it has that same exact impact, but probably will have impact in populations that have that as the epidemiology of why kids get sick. Yeah.
Can I follow up?
Yeah.
Do universities listen to you?
Do universities, in terms of,
Your focus is donors,
yeah,
but what you just described is really a research project.
right, yeah,
That is, we would love to have information
yeah,
on how this saving
Children's
children's
lives.
lives
yeah,
would work in other places. So everybody heard that comment.
yeah,
And some of you going on to do a PhD might say,
Yeah.
geez, I heard it first.
yeah,
Or maybe,
Yeah.
heard it here. But, you're in a university.
yeah.
Do you have any impact on this university?
On what they,
What they do in terms of research?
hmm,
Or on any, I'm just, your
It's
clientele
interesting.
sounds like it's donors.
Yeah.
but It's almost
yeah.
an issue for the scientific community.
It's,
too.
it's a definitely issue for the scientific community. And it's an interesting, as you'll find if you become an academic researcher, that there's sort of a dance between what the important questions are and then also what the funding organizations are willing to grant funding for. So I feel like, at least for the sector that I know well, which is global public health, is that this has become the issue. So what happened was, is everyone hear of the President's Fund for Emergency AIDS Relief, which is a PEPFAR program, which is our main HIV donation program from the US government? It was started by George Bush. Billions of dollars, amazing program. It was rolled out in multiple countries in Africa. And they really felt in the beginning that they're like, this dollars need to be going to save people's lives, going to medications, going to training, no research. This is all about. So now they're a couple years into the program and they have all these different programs in different countries and they're like, and they all were doing different things. They're like, well, which one worked and which one didn't? But they didn't really have a lot of the data at first set up, and this would have been a perfect way to learn. And so now they went back and they're like, "Rah." And so that's why there's a lot of research right now and implementation to understand, well, what's the best way to deliver care in this country versus country versus country. And so for the public health sector, that's getting funded a lot. And so because of that, so the University of Penn and the Epi department, we have PEPFAR funding in Botswana to look at delivery, to look at loss to follow-up, to look at ways to keep people in care. So I think it's also a lot of what's available for research grants, and sort of interesting how our original money was to deliver care in Botswana, but now it's also to try to figure out, well, what's working as you're setting up a delivery program. So it's kind of, I think it's a catch-22 in terms of the funding. Right? And these are just some examples. I just wanted to show some examples of programs that we've looked at. Community case management. So this is one where many children in the developing world die because of, does anyone know what the leading causes of child death are? Pneumonia. There's a few, Alice is in my class. So it's a lot of people will say like HIV or other things. It's actually pneumonia and diarrheal illness, which are things that are very easily treatable at the community level. And for so long, probably, doctors, this is probably a fault of doctors and other people, wanted to keep hold of, antibiotics and all. But we've done a lot of research in multiple countries that has shown that community health workers that are well trained and supervised can diagnose and treat malaria, pneumonia, diarrhea. And so this is just an example. And actually David Marsh of Save the Children, one of the organizations that sort of we got to know, I think originally through Dan, has been the proponent, has done a lot of the research trials on looking at this. So and there's been a meta-analyses in multiple papers of the decrease in infant mortality and under 5 mortality when you've looked across countries in multiple different studies. And you can put this into sort of models, and it's on average about $1,000 per life saved. I mean, it's pretty impressive. And these data are important because they really got ministers of health, other people that were important to change their laws on who can deliver antibiotics. I think they've really shown how important that was. Some other examples of high impact models that we've looked at, I'll kind of go through, yeah.
Another question. So if you go back to that slide, I'm just interested in what the student reaction to that number is. Everybody probably had a reaction. No?
The $1,000 per life saved.
Yeah, what's that mean? If you were a donor walking in there, what do you think? What do you think as a student? Hmm?
I know that it's a life, but from a donor perspective, maybe for them the cost is high.
I think coming from the education sector, that's a big number to
Number.
look at, yeah.
Per person.
I mean, it's worth it, and it's small in
Yeah.
terms of like, oh my God.
Most-
I think babies are worth far more than $1,000.
But
I could save 20 lives instead of doing a semester at Penn.
Yeah, so there's a good example. So how do you, as a donor, do you give money for scholarships? Or do you, how do you think about that? How anybody else?
Yeah.
It's kind of a striking number.
I think from another side, I think like it seems flawed on some level. I mean, I'm sure you have good metrics behind it, but how do you assign $1,000 to
Yeah.
life?
Yeah, and these are great questions, and that's why I said I was never like. Remember, I gave the preface in the beginning that the most uncomfortable part that I was is like doing any kind of money because I'm totally all about this side, because I'm like I can show that, and I fought it tooth and nail, kind of linking the cost and impact. But you ask any policymaker, any person who wants to give money, and they're like, I want to know what do I get for my money, and
Wharton School.
and I'm like. And so I've sort of turned into my kind of thing now is sort of like, here's the money and resources you need, here's the type of outputs you get. And that's the kind of what I like to kind of say it. My boss, all the Wharton people, they want it in a metric. And this is, I don't know if anybody's looked at sort of, or taking classes in cost effectiveness analysis or cost benefit analysis. These are like core policy things that, I mean, this seems actually as somebody who's not comfortable with this I'm actually comfortable with this because it keeps the units in at least a life. What they do in cost benefit analysis is they'll actually turn that life into dollars. So, which is how do you decide like a life is worth this much in this country versus that much? This is at least it's and all this is saying is that the program on average it took about $1,000 of materials, of antibiotics, of time to actually have, to have this many kids saved. So what it was really is that like a $2 million program may have over the course of 5 years saved, I don't know how many does that come out to, 400 children. And that's all it really is. But it's down into this metric.
Which is admittedly very simplistic, because you could look at this number and say, well,
Yeah.
many things.
Yeah.
What's the person earn in a lifetime?
Yeah.
What are the costs of healthcare in a lifetime?
Yeah.
What's the impact on the parents of the
Yeah.
10th
Yeah.
kid as compared with the 9th kid?
Yeah. And
Uh,
these
It
are
raises many uncomfortable
Yeah.
issues.
Yeah.
Like if a mother gets pregnant again because she lost her child,
Yeah.
or the cost of birth.
Yeah.
Like it's horrific
Yeah,
to put it in
yeah,
dollar
yeah.
terms, but like a healthy child, I think costs less than.
Yeah, and this is not like what a life costs. This is just saying for in a programmatic thing that your outcomes, this is your costs and this is your outcomes. That's all it really is saying. So it's not kind of putting a cost on a life. It's just saying what you're able to achieve as an organization. Save the Children, for example, on average for every $1,000 that you give them for a community case management program, they'll be able to probably save a kid's life. That's
So
probably
if
on
you
average.
translate this into education, one key area of investment of every Ministry of Education is training of teachers. So if you looked at the amount of money invested in training of teachers, which is one of the largest numbers that a minister, the largest budgets that
Yeah.
the ministry has, other than building schools,
Yeah.
is to train teachers, and you look at the impact of an additional hour
Yeah,
or an additional month of training, and you find that it's near zero.
That's the cost,
Yeah.
it says here? Wow.
Well, no, the cost isn't zero, the cost is real.
Uh,
The impact is near zero.
Oh, the impact.
So that it raises uncomfortable issues
Yeah.
for the Minister of Education.
Yeah.
They are being pushed into creating the same
Yeah.
kinds of numbers, which
Yeah.
are uncomfortable making.
Yeah, no, and I'm saying, like, for me, this is this is not where I come from, my training, but I will tell you from the last 8 years talking to donors, talking to policymakers, this is what they want and they expect. So it's been an interesting trying to figure out ways to understand efficiency in a way that is true to organizations and is true to things. And I think we're still learning and still working on this. We actually got invited a couple years ago to go to the Gates Foundation because they were trying to figure out internally how they were going to think about this. And there were organizations from throughout the country that presented their methodology, including, has anyone heard of Robin Hood? So an organization in New York who does a lot of cost-benefit analysis, organizations like RAND who do a lot of cost-benefit analysis, and trying to think about the pros and cons of this. And it's just really complex. The one takeaway I found from this whole thing is that this is garbage in, garbage out. If you don't have good data, good costing data, good impact data, why even do this in the first place? Because, and that's the problem. If everything's modeled and everything's estimated, then, and I think that's where we are now, is we don't have really good data. So I would just rather us seeing to try to get better impact information rather than being worried as think as much of the modeling. But so. Yeah, so this is a thorny issue, but one that was not going to go away, I would have to say. So maybe I'll just kind of mention a couple of these. These ones I picked because I thought they have a lot of overlap with education. This is one called care groups. So when we looked at some of the best programs for affecting child health, one of the ones, and this was actually the United States Agency for International Development has a child survival and health grants program where they give 5-year grants to nonprofits to work in global child health, and they looked across many of the different models they funded, and one of the ones that had some of the best impact was this program. So you're able to look across many programs, and it's really interesting because most of the time on the health side we focus on the supply side, like making sure there's doctors and nurses to give vaccines or antibiotics. This whole program works on the demand side. It works with mothers groups and really is an educational program to teach them about warning signs, to teach them about breastfeeding, and uses a peer-based model where one mom in each kind of area will volunteer to take on 10 of her friends' households. And so she'll learn a message, and then over the course of that month, will go house to house and talk to her peers about it and teach them how to do it. So it's really using that behavior kind of change. And they've looked, this is one that we actually worked with, I'm trying to think of World Relief, some of their data, looking at kind of the change over their program. And this is a very basic before and after, so the kind of lowest in terms of the levels of outcome design, but you can still see over time the uptake of interventions. This is for malaria treatment. So mothers who brought their children to get malaria treatment within 24 hours of fever, children who are sleeping under a bed net. So really had a lot of impact. And this is just to show you a little bit how this works. You have one health promoter who will then be in charge of 5 care groups, and care groups are groups of volunteer mothers, and then every mother in that group will go to 12 mothers. So you can see it's like it saturates the whole kind of community with, so every household is actually reached in a very efficient way. And here's another group that took this on. This is, I think this is Food for the Hungry's work in Mozambique, looking at uptake before and after a 5-year program of exclusive breastfeeding, vitamin A, deworming, oral rehydration therapy, and mothers who knew 3 signs of child illness. This is sort of the before and after. So really impressive. And this is one of the journals that I was excited that came out with implementation science. So this just started last year. It's a journal called Global Public Health Science and Practice. And it came out, it's a combination from, I think it's from USAID, Johns Hopkins School of Public Health, and a couple organizations who are really trying to get the practitioners kind of data, like this kind of data out in the field. And so for one of the first issues of this journal had the care group data, which I thought was really cool. And it's just showing that, looking at global child undernutrition, using this care group volunteers to communicate health messages. And so in the paper, they decreased under 5 mortality rate by about 30% with this model. And they actually did, in their own things, a estimated cost per DALY averted and cost per child averted. These are the kind of things that the US Congress is also very interested in terms of efficiency of programs.
Is there something special about that is this journal new because most other journals are less about practice?
Yes. Practice, I would have to say, there's not a lot of as many practice journals. There weren't as many practice journals in global public health. There's some policy journals, a lot of journals like The Lancet and those kind of things that will publish really good trials, but not a lot of places where you can publish this kind of data, which is not, they don't have a control group. They're not, so it's a lot of what a typical organization might be able to show. So this may be different in education, but this was I think a big move.
I don't know. I just wonder, I mean, there are many, many journals in education. And I would guess in health, because most people here have heard of The Lancet, because it gets a lot of attention. I wonder, how does a journal like this survive under the harsh glow of very well-known journals like The Lancet? I mean,
Yeah.
would it?
Well, The Lancet probably wouldn't publish a non-controlled study.
Exactly.
Yeah.
Exactly. I'm just wondering, would
Yeah.
this be given proper attention if it
Oh.
appears in this journal? Is it?
Well, it may,
how does
yeah.
it work?
But I think a lot of people realize now that the importance of the data from the field. And so if you're trying to figure out, well, what works, and you're a practitioner or you're a nonprofit trying to figure out programs that you might implement, sometimes what's published in The Lancet or everything isn't what you're going to be able to do. And so I think this is much more practical and much more usable to the practice community. So this is a practice community journal, I would say.
Also open access.
It's open access.
Which makes a huge
It's right,
difference.
yeah.
So we don't have, do we, in global education or international education, a practice journal? We're more stuck in that kind of conversation that happened
I mean, I
at
think that
CIES, which is,
I think there's definitely a move towards there. Like IEDP really only wants to publish stuff which has policy implications and value. They don't just want to track.
policy implications is not quite the same thing as
Right,
this, is
you're right.
it?
But I mean, I'm trying to think which ones might have more of a practitioner. Maybe not in education, but I think definitely in development you'll find more practitioner oriented.
Yeah, I'm just thinking in education, I don't think we have the equivalent, is what to my knowledge.
Well, this sounds like a perfect expansion opportunity. Look at you're going to have all these graduates out in the world doing this program, be sending you articles and publishing and place to publish.
Spread the news, okay.
These are just another one that I've really, getting back to that home visit story I told you about the first day of life. Similarly, home visits in terms of treating HIV has been found to be a great, really effective model for keeping patients in care. And this is not only in, low-income areas in Haiti, but also this is, they've done similar work in Boston. And these are the ones that we're now trying to kind of start. And actually, I don't know if anyone's heard of, at Penn last year, Shreya Kangovi started a Penn Center for Community Health Worker Research, where she's researching using great sort of, rigorous trials, how community health workers can be useful in working with the populations, like taking sort of the global local ideas. So the ideas that were kind of piloted and proven internationally and bringing now to our backyard. Because the kind of the innovations don't always have to happen at a place like Penn. They can happen in the field in India and can be adapted here. And we're now trying some of those ideas out. So I think that's the other exciting sort of the reverse sort of innovation. And so if anyone's interested in that, it's the Center for Community Health Worker Research. I'm sure there's lots of educational projects that could probably come out of that too. And here's one of the programs that I have found. If you're looking for a great model of comprehensive community-based care, has anyone heard of the Jomkeed model? It's kind of been for like 30 years. These guys have to do it for their paper next week. I hadn't talked that much about it, both in my class and I forgot that you guys are doing that. So here's this. So this one is a really fantastic one that actually tries to make linkages across education, agriculture, economic development, and health, and it really has some great outcome data based on these kind of comprehensive models. And this is kind of just looking at their project data compared to the rest of the rural area of Maharashtra, where they're from. So pretty impressive. And then here's another example. After the earthquake in Haiti, we started trying to look at models based in Haiti and what kind of outcomes did they have, and we had a very small amount of time to do it. So we looked at only sort of published literature for that one, and I wanted to show you one of this model, which I thought was a great example of these kind of things brought together: the home visits, the comprehensive, as well as looking at sort of education and clean water, which they do all of this, and they link it with a hospital system. And this is based in the kind of middle of Haiti, the Hospital Albert Schweitzer system. It's been around for about 25 years. And we kind of go back to those questions that donors ask, and we kind of think about that impact chain. And the first question is, what percentage of the population has access to the things that, you said that you were going to get to them? So here's their data before and after. This is their data, Hospital Albert Schweitzer in the dark purple compared to the rest of Haiti. So they were able to deliver a lot more services than the other public system. And then the question then becomes did this matter to anybody's health? Because that's the other question. You have to know the actual impact. It's not just delivery of services. Like if kids show up in school, that doesn't mean they actually learned anything. And so they were able to look at mortality data and show that they decreased by over half, the mortality rates. So very impressive. And then they looked at their costing because they were trying to make the case, is this efficient? We've spent a lot of resources. It's a philanthropically funded project. They found out that their per capita annual costs were about $20, and their cost per child death averted is about $3,000. I still think that this is incredibly impressive. Compared to, think about how much we spend on healthcare in the United States in terms of what we get for it. And this was a cost per year of life saved was about $40. And all this work was done by Henry Perry, who's at the Hopkins School of Public Health, and it sort of has published all of this work.
I've been thinking a lot about, on Dr. Wagner's question about reacting to that $1,000 or the $440 or the $3,000. And I kind of went two ways. One, I thought it was low. I didn't have the same reaction. I thought that's a lot of money. I thought that was low, considering the only place I've seen, sort of dollar values attached to lives is in construction, where insurance companies have to, when you build a big building, some people will die when you make it. There's no way to avoid it.
So
like 100 people die or whatever. And things have gotten better since 18, I don't know.
Yeah.
But still, it happens every time we build a building, somebody dies. And they have to work that in because it costs the company money.
Yeah.
In insurance payments and all that. And they assign values to lives. They say, we expect to lose 3 people in construction of this thing, and this is going to cost us this much money.
Yeah.
And there are, for like risk people, there are actual values attached to lives, and that's way higher than that. It's tens and tens of thousands. So it first struck me as low in that way, and then I thought about like GDP per capita.
Yeah.
And you can kind of think of it as a measure of how much wealth a person, on average, person creates in a country. That's kind of not right, but Alice and I just looked at Tanzania, and it's like $600 every year. So that means that person is going to make that up in 5 years of work, essentially. Make that up. That's also sort of but it seems low. Even 3,000 is like, oh, it's cheap.
Well, and this is the way I also think about it too, is that, so in health, there's a lot of health economists now, and they'll use this cost effectiveness analysis, which they do cost, and they do it in this, either in DALYs, which is kind of a life year. Think about it as like a year of healthy life. And so there's lots of data on what interventions and how much they cost per year of life. And it's usually in years of life, because that seems what most people use. You might think of even QALYs in this literature, which is quality adjusted life years. And then actually, a lot of people in other countries, not necessarily our own, because people will call them death panels, so we're not allowed to use the term rationing or anything with our health system, but in other countries that have socialized medicine, they'll decide of what their public system will fund based on the cost per DALYs or cost per QALYs. And so it's used all of the time in terms of it's more of like how much benefit do you get for the dollar, which is difficult because things that are new or things that aren't tried, it's harder to kind of get access to. But I think it's a way, I'm not sort of promoting the sort of cost per anything, but I think it's a way to also just think about a way, if you're working in an organization or working in the field, is to try to realize that having some, you don't have to put them together, but having some data on your costing is a huge area of, there's almost no information out there. And so if you're interested in economics and costing, is trying to understand the costs of things and programs data, there's a huge literature and need for, I think, that space. It's really, really needy.
But you have this very strange task. It's almost like a religious task. Somebody comes in and says, I have $1 million. I want to save lives. You say to them, well, you can save more in Haiti than you can save in Malawi. We recommend Haiti.
Yeah. So we never get donors like that. So, and we don't have say anything. So, the other thing is that, and they don't ever ask us that sort of question. So, it's usually people will come in and say like, and people. The other thing I should say is that we don't directly advise. Right? We create information resources to get out there. So we're not trying to say give to that country.
So
we put together
the data
data.
have implications, right?
The data have implications, but I think so. For example, if you're trying to prevent malaria, well, there are good ways to do it, and there are not so great ways to do it. And so we do it within a context of what you're trying to do. So if you're trying to improve school attendance in country X, what are the different ways you could look at to do that, and what are the different outcomes and costs? I mean, that's the kind of thing that we think about. We're not trying to direct you to health over education or one country over another. That's not the kind of work that we do, because it's not really a question. I think that's, but there are people that will do that, and there's actually books. I don't know if people have read like The Life You Can Save, and there's a lot of groups out there that take it from a bioethical perspective of saying that, well, you should do the most that you can.
There are books like that.
Yeah, there's
So if you followed that line of thought,
So-
we'd be all investing our early childhood money in Detroit,
yeah.
because you get more bang for the buck in Detroit.
I
But
mean-
nobody's followed that.
But think about it. So you save their life so that then they don't have any education. What kind of life is that, though? That's what you kind of, because you have to really take it to a realistic, and that's why I said we think about it as sort of, okay, so in the education space, this is a question I would ask you guys. So in international education, you're working in Malawi and you're trying to increase secondary school attendance. What should you do? And that's when you can look at the different models and compare the costs and the outcomes of them. And that's kind of they're all trying to do the same thing. I think that's where this is helpful as a
What
tool.
do you do?
I don't know that space, so you have to tell me. What would you guys recommend doing?
I guess there's a little bit of misunderstanding of the cost-benefit analysis and also the life saved per term.
Yeah.
I think there is no causation of the money and
Yeah.
also the outcome of the project. All those calculations and mathematics are just, try to calculate, try to build the
Yeah.
correlation of the
Yeah.
money and the life. There is actually no causation between this. This
Yeah.
does not mean that if I put $40
Yeah.
into it, I will save one life.
You're right.
There's no causation.
You're right.
Calculation.
This is on average over a program. So you're right. And that's why what I like to do, this is what I think is better to say, this $2 million program, which also included this many staff, was able to achieve this outcome. You know what I mean? And I think that's the way I like to phrase it. So when I talk, that's usually what I do. Now my business colleagues will, they were like, well, what is that on average? What does that get down to as a per life? And so it's very interesting. You'll meet different people that want that want communication different ways. So it's an interesting challenge, and it's one that I've sort of been challenging myself and struggling over time. And Dan asked us to talk about struggles, and this is one for me that it's been uncomfortable, and I'm still not comfortable putting connecting the costs and the outcomes. So.
And I would say in the health sector, and just in case you're not aware, I mean, there is a whole counter movement, right? There's, I would put maybe Paul Farmer in that group.
Yeah. Oh, that's a great point.
That says that, well,
Well,
you could
yeah.
probably say it better than I can.
Well, the interesting thing, so this is if people, remember I told you about that cost effectiveness, and people will decide what they're going to fund and not. Or it will say something like, oh, that's not cost effective. Cost effective does not mean cheap. Okay, cost effective means do you get the outcome that you want for the cost, okay, the additional incremental benefit for the incremental cost. Well, when you think about, here's an example of, there's a lot of programs for multi-drug resistant tuberculosis, okay, back years ago. So Paul Farmer worked in Peru, and there's a lot of multi-drug resistant tuberculosis. And everybody said that, too expensive to treat. These drugs cost thousands and thousands of dollars per patient. So we can't do it. It's not cost effective, whatever. But when you actually look at the drugs, there was only like one manufacturer of them, and because of that, the price was really high because there was not enough people buying them, and it was all of these things. So when they actually went and were able to get more people making the drugs and more availability, the price dropped so much, and then it became cost effective. So you realize that it's not necessarily, it's all about the inputs. And so I think more cost effective stuff is more of a tool to problem solve, is to say, okay, if that doesn't seem cost effective, well, what are the inputs and what is actually movable? That's the same thing happened with HIV medications. For so long, people were like, HIV medications, way too expensive, we'll never be able to do this on a population-based level. Well, when they actually got generic medications into the thing, the prices dropped from thousands of dollars a year to now about $100 to $125 for a full year of HIV medications. So you also have to realize the inputs to these equations are changeable. And so that actually, as a sort of an advocate or as a policymaker or somebody, you can use them as we do sensitivity analysis, so you can look at the main drivers of the outcome and then figure out, can I change that input? And so I think it's more I think it's more of a planning tool to actually be able to problem solve. So, yeah.
I was just wondering with regard to donors again, when I said the 1,000, just to repeat
Yeah.
twice, it's not that I
Yeah.
think it's expensive. It's just that I think that many donors are attracted by scale.
Yeah.
So how do you like balance
Yeah.
impact and scale?
Yeah, that's a
And
great
just
question.
I think that life has always, in public
Mhm.
health, you draw life as the line between what's effective
Yeah.
and what's not
Yeah.
effective. And in education, we don't have a
Yeah.
similar.
Yeah.
Or at least it doesn't have
Yeah.
that. And how do you like think, you know, the
Yeah.
5 who survive, the article like, we set mortality as
Mm.
like the margin of what works and what doesn't.
Okay.
What about when you survive
Yeah.
and still you have stent and iron deficiency?
Yeah. These are
You're
great.
there, but you're not really there.
Yeah, and I think that's why I was mentioning like that we would never tell a donor to like move money from education to health or those kind of things, because I think like you were saying is that if you survive and you don't have education, other things, like what kind of life is that? If you're trying to though achieve like one goal is so a newborn doesn't die, then there's good ways and not good ways to do that. I completely agree with you in terms of thinking about the scale question. And if people are interested in this, the World Health Organization and Health has a whole group called the Choice Program, choosing programs that are cost effective, and a whole modeling thing where they actually change the costing based on the scale. Because as you can think about, if you're starting a program, it's much more expensive in the beginning when you're just getting started. It's much less expensive to add people from like the 25% maybe to the 75% when you're reaching your target population, and those last 10% of people are incredibly expensive to reach. So then the cost increases again. And so they'll do their analysis based on actually scale and percentage of target population. And so they realize exactly what you're saying, that the costing is very different based on scale. And I think the interesting thing about these analyses is that they have the programs now that because in the ideal world, what you'd want is it to use as a planning tool that ministers of health or finance or education could plug in their own local data and their own local costing and kind of say, okay, well, to plan as a planning tool. And that's what they're trying to create for people, is so that you can say, if you know the data on how effective it is to increase, girls' education by, offering, uniforms versus deworming versus, a conditional cash transfer, then you can look at the differences, in your own country and the costing. So, which would be great. But, yeah. Yeah. Oh, one question. Yeah, Allison.
Yeah, I was just going to say, I think also time is always a factor in cost
Yeah.
benefits. So we might say 1,000 to 3,000
Yeah.
saves a child's life right now. But
Yeah.
if we spent that 3,000 somewhere else, but wouldn't see the benefit for 10 years,
Yeah.
that's not what people want to see. They want to see the benefit right now.
Yeah.
And I think it's hard to exactly do cost benefit not knowing what time frame.
Yeah. Yeah, and this is, I think, what, again, I'm not saying, I don't want you to come away with the thing that I'm all about cost effectiveness, because it's the least thing that I do. I'm actually much more of a health person. But this is good because it's questions, because it's something that I've struggled with, and so it's good to talk about sort of things. But in cost effectiveness analysis, and this is another thing, there's a huge debate in literature about whether you discount. So you're just talking about this, because $1 today is more valuable than $1 in 10 years. And so all the financial people, the accountants, the economists will discount it 3% per year. Okay, and so they discount costs that way. So their whole idea is you have to discount benefits in the same way. Okay, so what they'll do is they'll discount benefits. But what they do is they discount, so suppose you have a program that saves a baby's life. And suppose that baby will now then, their life expectancy would have been 60 years or something. So you would think, oh, well, that program saved 60 years. But they'll discount it 3% per year, so you actually only get credit for 25 years. And so when you actually look at that, then what happens is what it does is it actually will say that it devalues children compared to older people in some ways. And so there has been all of these debates back and forth in the literature. And now when you see some of them, they'll do it with discounting and without discounting. But this question comes up, is and these are all these economic kind of things. But again, this is a very full of debate and controversy area.
Well, it's really fascinating. We're almost
Yeah.
out of time here,
Yeah.
and we've interrupted you
This is
a
great.
lot.
Yeah.
But I think for the right reasons.
I'm just going to put one slide.
These are issues that I think we
I'm going to put one
Oh,
slide
we
left.
haven't gotten your personal.
No,
chart?
I'm going to finish up with 1 or 2 slides of my personal thing. Yeah, if that's
All right.
okay.
Go ahead.
Because I don't want you to kind of walk away. I don't want you to walk away thinking I'm the cost effectiveness person, because I'm not. It's not sort of my passions. But my passion is sort of, and how I kind of, I was going to come back to it sort of the end, is how I got sort of interested. And this was my first international public health trip when I was actually in college. I went to Haiti with a group from Princeton, where I was an undergrad, and was working with a small nonprofit. And I did a homestay with this Haitian family. And this is my Haitian family. And I remember asking him, the dad, at the end of my trip, through a translator, because I didn't speak Creole, if we could do one thing to help, Haiti, what would it be? And back in my mind, I was thinking, oh, well, he'll want his children to have health care or education or something like that. And what he said to me was so profound, and I keep this picture above my desk to help remind me, is he said, to end an era when decisions are made about us, far from us, without us. And to me, this was like, and I keep that there to remind myself that when I really think about health development or whatever I want to do with my life, is it really, in the long run, development is just this, is it's having people participate and make decisions for their own outcomes. I mean, that's what I want for my family. That's what I think every parent wants for their own family. And so thinking about, as a development practitioner, which I think I am, is that, how do we get to that? How do we enable these families to take part in the process, to enable them? And I think the way I've sort of have been, my career is kind of developing, is I've now in the past couple of years been switching, and I'm doing a lot more of our training programs at the medical school. So now I co-direct, we have a tract in our internal medicine and pediatrics program called the Global Health Equities Track. So we train our physicians who really want to dedicate their lives to this in global health equities. And a lot of it is trying to develop partnerships with our partners on the ground who are trying to do the same thing. So can we develop, our workforce who tries to see the world, to try to not be the one that comes in with the answers, but ones that can actually be the ones that help empower and provide resources to locals who have ideas. And need the capacity. So that's kind of where I'm trying to kind of figure out, and it's funny because I looked back on my senior thesis in college, and it was called The Missing Link. And I was really interested in sort of how do you connect community-based development, sort of the bottom up, with technical innovations from the top down, and sort of where is that space in the middle. And that's kind of where my sort of personal interests and my research interests really are now, in sort of intermediary NGOs, intermediate training programs that can do that in a way that that local people don't have to reinvent the wheel, so that they can use the resources, knowledge, technical assistance that people have, but they are somehow the drivers of the process. So that's where I'm trying to think if I have a quote. I'll have a quote. I was going to show you these ones at the end. This is the one I was going to say. That this was one of my heroes, who is one of my mentors at the Hopkins School of Public Health, who's Carl Taylor. And this is his book. If you're looking for a great book, if you're interested in this, it's called Just and Lasting Change: When Communities Own Their Own Futures. And it's really what we're trying to scale up is not technical, but a process to support communities and develop their own solutions. And I think this is sort of my quote that all of my sort of trainees and my students will see I put up all the time, is that I always think, if in training programs, train people to be good leaders. And good leaders, I think, are those that, when their task is accomplished, when their work is done, the people will remark, we have done it ourselves. And I think if I walk away and my students can be these kind of leaders, I feel like that's the sort of the development practitioner that, I hope that we can create. So anyway, that's my end. Sorry. Just wanted to get to that, so you don't walk away and think I'm the cost effectiveness person.